what about benefit design, Jeffrey? How can employers perhaps change the benefit packages that people have to make this work? Or is that even possible? There's a little smirk here. So,
well, yeah, I mean, it's a good question. I mean, how can they? I mean, it's fairly easy for them to do it, but the question is will they and how do they do it? I think employers need to understand what the offsets are here. So as clinicians, we understand it, but I'm not sure employers understand it to the point that they're willing to pay for these things. But I think Maria hit upon a good example earlier, and it's the smoking cessation. So I think that's how we're going to have to approach this. Is that one way of doing this is that in order to get access to these drugs or these services, they have to be enrolled in other programs. So like to get smoking cessation products, they need to be in programs or classes that teach them, coping tools and those types of things. I see the same thing here. And there has to be a bunch of different people involved in this. So the provider, the payer, and the patient, and there has to be other things involved. Mm-hmm. So I think that's probably a step, or at least the next logical step would be offering these types of programs as part of access to drugs.
I want to get on to bariatric surgery, but Marie, you said something, and I don't want the trigger to thought. I don't want to lose it. The Medicaid population, often a lower income population, may not have access to the kind of foods we would like them to eat. They're the ones who are going after the fast food because it's cheap and available. I mean, how do we deal with that?
Well, I think that's where, again, a multi-stakeholder approach, particularly with government, in an environment where, as a payer, we actually, there was a time when we actually tried to incentivize our own employees to eat well, and we had a relationship with local diners. So every time they purchased a meal item off of a healthy food menu, we subsidized $1 for every $5. So this is where, again, this is part of a multi-stakeholder effort where government, hopefully, there's a tax or there's a levy or you're subsidized healthy eating.
I just want to put this out there, and we're going to keep going. I've surveyed hospital cafeterias. I've worked in a bunch of hospitals. Every last one of them is serving eggs, bacon, butter, red meat with every meal. And in fact, the more expensive rooms get the higher cholesterol meals. I'm just going to leave it there. Hospital Administrators of America, take note. And let's go on to bariatric surgery, because the benefits of bariatric surgery include substantial and sustained weight loss and improvement and some resolution of comorbidities, including type 2 diabetes. But the costs, the surgical morbidity, and its risk are also a concern. Now, the Roux-en-Y and the so-called metabolic surgeries produce more weight loss than band surgeries and uniquely affect hormones and some signaling pathways. These have been suggested as useful for controlling type 2 diabetes, but few data exists supporting the use to control diabetes outside of class 3 obesity. These are fairly large people. So for which patients would you consider surgery over medical treatment of obesity? And would surgery ever be your first choice?
Well, I think it could be, I'll start from the end. I think surgery could be my first choice, as I described before, the relatively sick patients that come to me, that I will start talking on medications and I'll start talking on diet, but I know that that patient has been sick, and if they don't lose a real fast amount of weight, they may not make it in the next 3 years. So it could be my first.
These are BMIs of 35.
Correct. Even 40, and then they've got already heart disease, and glucose is not controlled, and blood pressure not controlled. It could be. But at the same time, we need to recognize, we talked about 30 million people with diabetes, 18, 19 million people with pre-diabetes, 100 to 150 million with overweight and obesity. As many says, you convert everybody to surgeons. You cannot use it as your main first-to-go treatment. So I think that we need to recognize that, and I think that we need to use it for those patients who need it the most.
So from a cost perspective now, what financial benefits are associated with medicine versus surgery? And do you think that the savings from the long-term weight loss with surgery, if it's borne out by research and by data going on, would offset surgery's high upfront cost? I'm not even talking about getting everybody into an operating room.
Well, I think that that's certainly the practical approach, but I think we want medications to work. I think we want to see that the approach works, just like we're seeing that the approach works with surgery. So I think from a comparative effectiveness, what we're looking for in medications is something that doesn't have the complications, the sunk cost in the surgical procedure, the morbidity associated with these procedures. But we need a committed patient, because anyone that goes for bariatric surgery is going to need to have that degree of commitment. So we need a committed patient. We need drugs that actually work. We need the support. And in terms of what does work look like or success look like, it's meaningful weight loss. And it's weight loss that also leads to a reduction in the comorbidities. So if we all of a sudden start to see that the diabetics, their A1C are in control, and we can actually free up other medications that they've been on, there's the ROI for you, because then you're cost offsetting in terms of the comorbidities and other agents that they may be on.
It sounds like a salary cap in professional sports.
Absolutely.
No, I mean, she hits on the two key points. It's the appropriate patient, and it's the ROI. So, and it's the data. Is this going to be an add-on cost, or is this going to be an offset cost? And if you can avoid other things by doing this, then it's a different model, different proposition than just delaying and adding on costs.
But to look at that, I think the reason we kind of look at surgery first, that for a long time we had either lifestyle, some medication that worked only for a short time, and we did not really have good long-term medications. So our only option was surgery, and some insurance companies would pay for surgeries and not for medications. I think now we're turning the tide again. Look at heart disease. We do lifestyle, we give medications, and many times medical therapy is as good as surgical intervention on many of the cardiovascular patients. We are going to see here the same thing. The nice thing about obesity management is when it doesn't work, the patient stops the medication and will not continue on it. And those that it will work on will get all the rest of the benefit. We need to recognize, again, individual therapy. Half the patient, 40% of them will benefit tremendously, and then the other ones will not benefit so much, and they will get off the drug. So the cost will not be really borne if they're getting off.
If I can take, as a physician, I'm entitled to take the biggest picture ever. Government can't do it. Finance can't do it. But if you can control type 2 diabetes by controlling obesity, and people live longer and stay in the workforce longer, then they pay more taxes, and there's more money for everybody in healthcare. What am I missing here?
They're expensive patients.
They're expensive patients. But or what you're really saying is that death is less expensive? Is that really it?
On tape, I'm not going to say that.
Nah.
No.
Well, saving life is expensive.
Yeah.
For long term, for sure.
But, I think there's a price to be paid for something that works, and a price to be paid for innovation. Look at hepatitis C, price to be paid for innovation. Look at HIV, a price to be paid for innovation that's a cure. So I think there's plenty of room to move beyond where we are, but I think we want to see that these agents really work in moving the
Managed care and
comorbidities.
payers are not adverse to that. Again, the challenge is they have to think from the business perspective as well, so they can't be disadvantaged relative to their competitors. So I think clinically we're there and we understand it. We just need somebody to help us.
Look, I can make a case that the most expensive thing you can do in terms of healthcare in America is wellness programs. You keep everybody well. They live longer. They consume healthcare for another 20, 30 years. If you want to reduce the cost of healthcare in America, start smoking. Get rid of seatbelts. Get rid of helmets. Lots of steak, and don't treat your diabetes. Everybody dies at 35. It's cheap again. That's not where we want to go, is it, Jim?
No, you've got to do the right thing, and I don't think anybody's going to disagree with that. So we just need to figure out how we're going to spend the limited amount of resources we have. That's the challenge. It's not that we don't want to do this. We know we have to do it.
And that's why prevention is so important. And that's why the role of government is important. The things that are happening. The YMCAs across the country now are part of a nationwide attempt to introduce physical activities relatively inexpensive. We talked about the expensive food, green food or lean proteins and stuff, how expensive it is for the low-income people. That's not the only issue. There are areas in this country that you cannot find a produce shop in 5 miles area or 8 miles area. And now there is at least 2 groups in the United States that are trying to introduce it, some of it actually through the Walgreens and other, to make sure that they have a section with some fresh produce to get there.
I would agree with everything that's said, and it's really aligning all of the stakeholders, which in this case is patients, medical groups, government, social agencies, everybody that can really has some say in the game.
And they've got to have risk. They've got to have skin in the game, or they're not going to do it.